of YOSI. I would like to invite Dr. Pratyush. He is a panelist and he is just going to start his VR fellowship. He was in railways, I think, and yeah, and he will be there for the uh, discussion, and we will be shortly joined by other panelists. So the first topic of today will be by Dr. Kaushik Tripathi. He is in ASGI Hospital, and he is the head of academics in the ASG group of hospitals, and he is going to talk about ethical use of artificial intelligence in research.
Thanks, Nilesh. I'll thank everyone present here and YOSI and AIOS for giving me the opportunity. So I'll try to keep it simple, discuss the fundamental principles of research, rules of robotics, what is the simple process of AI, and what are the challenges we face with AI, and challenges with authorship, plagiarism, and what online tools we can use to enhance our research. So basic principles of fundamental research ethics are that we should respect persons, and there should be beneficence or non-maleficence. That means patient should not be harmed, and there should be justice. That means the control arm and the intervention arm should be judicially planned. So Asimov's three laws of robotics say that robot should not injure a human being, and robot should obey the orders by human, and robot should protect its own existence unless it conflicts with the first or second role. So AI, actually what AI does, it gathers the data. There is input, then there is processing by machine learning and neural network, and then it can perform tasks. So it can generate data or distribute data. So what are the challenges? Challenges are that while you are training the machine, the ownership of the data is one challenge. Specifically in healthcare, who owns the data? Like there might be multiple stakeholders, including patient, healthcare providers, the organization, and the data analyzing company. And there can be, like, in profitability also there may be shared stakeholders. So privacy and protection of data are very important settings. In European Union and USA, we do have multiple guidelines. Cyber security and leakage of the data is another thing, and data should be shared with privacy. So another thing is how accurate is the machine. So their machines can hallucinate. There was this in Medscape, this article came. They saw that ChatGPT provided correct answers in around only 29% cases, and it incorrectly reported black box warnings, which are very which can actually harm patients. So we cannot rely clearly on machines, and the transparency of the process, how it is processed. It is usually patented or usually proprietary information by large tech giants, and there is the intelligibility or understanding of the process is difficult and not possible if you are not inside the organization, and this creates a black box phenomena, like what we do not know what is happening inside the AI and how it is giving the response, and if something wrong happens, it is difficult to correct because you are not knowing what is happening, and the bias of the data can come from the data itself, from where the data is generated. So definitely there are issues of patient privacy, patient consent should be taken, and if the data is again there should be clear mention about how the data is processed, and does it need repeat consent if it is sent to some other party, and there can be possible harm of also. As I said, there can be AI can hallucinate. So physician related issues is that though it has not happened now, many people might depend much more on machines than themselves, and they as it is coming that people are thinking that machines might replace humans, and trust and empathy are something which machines lag as of now. So also, can we put accountability on the AI this is one fact for which authorship, most of the journals do not allow AI to be author because they cannot take responsibility of the AI, and costs are huge, and there is a possible chance of harm to humans. So this is there have been multiple articles which try to include ChatGPT or similar chatbots as author, but subsequently when this article was published, ChatGPT was removed from the article because this ICMJE, they provide guidelines for authorship. In authors, for you to be author, you have to provide, you have to contribute substantially to the work. You should draft the work, and you should approve the work, and you should be accountable and responsible for the data. So if you cannot be accountable, then you cannot be author. So plagiarism, this is like, there are some, if you are using some other person's data and you are passing them as your own, then it is a plagiarism. There are multiple AI generated tools which can paraphrase the content so that it is not detectable by standard plagiarism detection tool. So there are multiple criteria by UGC which punishes if you are plagiarizing. So this is a sample authenticate report, and their publication is not just something you cannot publish anything, because there are certain guidelines, and there are sites like PubPeer or Destruction Watch which are screening the data and seeing if there is any scientific misconduct. So I use ChatGPT, Notion, Zotero, Grammarly, and Elicit for my writing. So thank you.
So thank you, sir. So that was a very, I think it is a very elaborate topic with so much incoming into the in AI space. Recently, I was hearing an interview of one of the startup founders, and he was telling he has this idea, what you talked about, where they will feed up their doctors will rely more upon AI to diagnose the patient. So his idea was, every time I go to a specialist with fever, he just gives me Dolo. So why I have to like spend a day and do this? I just can enter my symptoms into, I can select the symptoms in an application, and the application will tell me what drugs to use. So I think that is the abuse of AI that happens. And Dr. Pratyush, any comments on this?
So during my dissertation, I have used ChatGPT 3.5 to some extent, but not like the whole dissertation. But yeah, it can be used to fill up spaces, but we cannot rely upon the results from the ChatGPT.
And also the accuracy is not correct, because
Accuracy
the
is
data,
not correct.
the data on which it is like a generally available website data. So professional
correct.
data or ophthalmological related data is not there.
Not correct.
So you will not get good scientific content, or you cannot rely on that कि ये मेरा बना देगा सब कुछ. It is not there.
Yes.
हो नहीं पाएगा अभी तक. Thank you.
I'd just like to invite Dr. Digvijayan's opinion. Sir, if we train an AI model with scientific, like what sir is saying, it is all off the website. But if we are training the AI based on the articles that have been published for like last 100 years in ophthalmology, will it be ethical? I'll just ask your opinion and then sir's opinion on that.
I think two aspects. One, that AI is as good as the data that you give it, and two, medical science, especially, this is a very much of a gray area. You can get one article for something and one article against something. So you will have to really think in terms of what is the strength that you're going to give it, for each of the articles, as in which article does it accept more and things like that. But as far as using it for, from a screening point of view, as long as it's just the first step and it's supplementing your work, I suppose there it's going to do a good job.
There are sites already doing such work. Elicit.org or elicit.com is a site in which actually you can put your data, put your research question. It will give like top 5 or top 10 articles which have been cited maximally, and it will generate a like summary of that. So there are multiple AI startups which are starting, and they can give you what you want. But and also this PubMed database, PubMed Central and PubMed database is one huge database. If some AI can actually capture all the available data which is available in PubMed, then actually it can generate a reasonable response. So,
Will you accept that article if it is generated from AI?
no, actually, human has to intervene because AI cannot take responsibility.
Yeah.
It say in the last it will write that please use your judgment or AI response can be wrong. So that is one thing. It is generating something, but you have to be responsible for that. If you are responsible, if you read that, and if you think that this is okay, you write in the acknowledgement that this data we took help of ChatGPT by OpenAI for production of this data. That's it, and we take responsibility of the work.
So, for example, I mean, if you look at just NAION itself, right? So, there, I mean, if you were to look at treatment of NAION and you put it on ChatGPT, or you want to see, it will pick up a lot of the studies by Dr. Son Singh Harre and all, which were patient choice studies, which are not exact. And today we know over time, and though we still don't have a proper RCT, today we know over time that things have changed, and we no longer really follow those blindly. But that is among the top answers that it gives you. And so if you're using that to whether it's in your clinical or you're using that to cite it in your own paper, you have to really look at it. It's not. I mean, I think as of now we still haven't reached there.
And also you can write in ChatGPT, if you are asking something, you just ask, please give me an idea of treatment of NAION for ophthalmologist in a professional tone with references. तो आप अगर ऐसे डाल देते हो, specify कर देते हो, तो it will give references, and you can say like 5 sentences or 10 sentences. It will actually generate a summary along with references. तो ये आप कर सकते हो. The comments or prompts are very important.
Hi. So I would like to welcome Dr. Priyam on the panel. More on ChatGPT will be dealt by Dr. Aditya Sethi. He is going to talk about ChatGPT in healthcare. Is it a boon or a curse? So, frankly speaking, I have used ChatGPT to generate blogs for my website, where I was talking about lenses, and just the first, I think, the definition it gave was was there, and everything rest was same for even for toric, multifocals, everything. It was giving the same things. So, more about it by Dr. Aditya Sethi.
So just to start the talk, I think it's not fair that we are comparing ChatGPT with the human brain. And I don't think it's fair that we're comparing any sort of AI with the human being, because if you even have to compare two people, you have to have them with the same age group at least. So AI is at a very nascent stage. At the same time, AI is made by the human brain, so it will never go above it, because whatever we feed, it will grow. So it's dependent. It's like a symbiotic relationship. It's not one versus the other as the movies show it. I think it's got to do with both together. Can I have my slide? Yeah, so like everything else, it'll have a boon, it'll have a curse. So this talk that was given to me was talking about both sides of the coin. So I'll explain a little bit here, a little bit there. And even though it was ChatGPT, is it in healthcare? I've broken it to a little bit of AI, because I think ChatGPT is absolutely baby. So it's very difficult to compare it or even say it's a boon or a curse at the moment. I have no financial interest, of course, but I did spend some money and got ChatGPT 4.0 for experience sake, for getting this hang of it. And a lot of you have seen WhatsApp, a lot of random posters coming in from me. That's because of ChatGPT 4.0. All right. So basically, AI is just about eyes in the sky. It talks about nowadays where it's really affected already is drug discovery. A lot of drugs which are coming in now have been chosen, or the modifications have been made by AI. So you must have read in the newspaper, new cancer drug has come out and it's looking very promising. Or you must have read that, there's a new type of insulin in the market, or a weight loss, this thing going, which Elon Musk also tweeted. All of that is coming from drug discovery with the help of AI. It's not just AI, it's with the help of AI. It also improves the speed and accuracy of diagnosis. One day I got a call from one of my colleagues who said there's a new EMR. And this EMR, I just punch in what the patient has and it's telling me what medicines to give. So it was shock and awe. Do you understand? So all of this is coming because of AI, and it's just basically whatever information we give it, it implies. So whether it's correct or not, it's got to do with the fact that we are there, and if we are giving wrong information to it, it will reply in a wrong information. EHR or EMRs as we call it, a lot of data we have, we don't know we have. We don't analyze it because we don't have the time every day. So AI's job is to make it smaller. Robotic surgery, we had a whole debate on it, and yesterday itself, there was an article which came that the first vitrectomy by a robot was done in Belgium. So I thought it was one day late because we had a debate the day before, but yeah, great. So clinical trials, of course, there are a lot of talks about AI in clinical trials. So basically, AI is not new. It's been there for a really long time. In 1950, there was the first paper which spoke about can machines think, and it laid the foundation of AI. So it's called the Turing's test. Turing's test is an evaluation of any AI, whatever you use in your day-to-day activities, which compares it with the human brain. It says, does it have even a close to ability to think like the human brain would? So this Turing's test is very important. And basically, the idea of AI came across as just to augment the human brain, not to replace it. So this is the evolution timeline. If you notice, there was a lot of big gap between 1960 and 1997, which is called the AI winter. So here, AI took a lot of beating. It did not do well at all. And then slowly started getting it do its groove again. And today we have a lot of AIs at the click of a button with us. So AI's impact on healthcare, basically 2 decades it's been used in healthcare. It's data driven from EMRs. Now we have massive data sets. All our glasses have AI in it. So data is going from their watches, your Fitbits. That's all data. And that data, what is the regular heart rate of everybody? Like it's like everybody going through a scan every 5 minutes. And all that data goes somewhere. And AI is one technology of analyzing that and coming up to better things. So ophthalmology is absolutely the best place for AI because everything we do is data-based, image-based, and rich in getting information out. Every photo you take, every biometry you do, every refraction you do, everything is data. And that data correlates to something. And that is where ophthalmology and AI come together. So basically, the significance is one of the earliest studies, which was 1970, was a CASNET study. This was basically to find out glaucoma consultation programs with the help of AI. So what we are talking about is as early as 1970. Of course, this was much before the winter, so there was a lot of gaps. And we've all heard of the mycin design of antibiotic to find out which is what sensitive to what. This was one of the most inspiring AI technologies which came out, and that's helped in choosing the right diagnostic tool, the right medicine, the right antibiotic. So again, pointing out that ophthalmology is actually a very good place for AI to be used. Various milestones in ophthalmology. The first FDA approved AI was for diabetic retinopathy called IDXDR. And basically, this is FDA approved in the sense that you don't need a doctor to interpret the results. So that's where AI has made it easy. So this is a good screening tool. Again, I'm still pretty sure in the US and everywhere else, this can't prescribe medicines, but it can take a picture. It'll tell you what sort of level of diabetic retinopathy you have so that you can go for a consultation or forget about it. That's how it's being used right now. So spectrum today is basically there are 3 types of AIs. We have ANI, which is narrow intelligence. We have general intelligence, which matches or exceeds the human, and super intelligence, which surpasses, which we're very worried about. It comes in Netflix movies that, oh, that's the end of life. That's how it is. So currently, most of it is just ANI. That's narrow intelligence. That means it requires the human brain to perform. So ChatGPT. ChatGPT is basically, we all know about OpenAI. It's been in the news for a long time. It's easy for us. We've all heard articles come out of it because it was so easy. It's basically, I feel it's the iPhone of AI. It's as simple as that. How easy iPhones are to use, right? You can't go wrong. If you delete a photo, it takes 20 more minutes to delete it. And probably 20 more days it'll be in some vault somewhere so that you're sure you want to delete it. That's how easy ChatGPT is. You just put in anything, it gives you a result. Now, most of us need to know how to use ChatGPT to actually get the maximum out of it. And that, I think, is an art itself. It's like a Google search. You can Google search, where do I get good food? Or where you can write food, Calcutta, this place, this place, this place, and you get the best results. And this speaks for itself that how much the market has grown with AI around it. So it's actually being used whether we are on board or not. So ChatGPT in healthcare has various benefits. It has service and other benefits in healthcare. You can implement it directly to your EMR now. You have customization needs, guidelines, resolving, and basically alternatives are being looked at. But what we are really interested in is the deep learning and CNNs, which basically look at images and they give you results. So this is where diabetic retinopathy, ARMD, glaucoma screening, all of this comes into play. And all it does, it takes fundus photos, OCTs, it collaborates the data together, and learns how to give you a significant diagnosis. Again, milestones AI, all have been used. Diabetic retinopathy, now we have the FDA approved, which is supposed to be highly sensitive, 87.2% and 90.7. A lot of what I went through articles quoted that this is as significant as a experienced doctor picking up lesions. Glaucoma detection also has been quite sensitive. We have ARMD, which is now a new promising software which is there and is working. So real world impact, we had the Watson. We know Watson from the Hello Watson shows in the UK. So it's actually been, IBM Watson has been used in personalizing treatments. It personalizes as per the patient. Sometimes you don't have the time to find out exactly about the patient. The AI can help you there. Google AI, of course, we've all had Mr. Sundar Pichai come and talk about how he took one selfie and you could see his scan. So that's where Google AI is doing really well in screening diabetic retinopathy. And there are a lot of new projects coming in because technology is something which grows. This is the diabetic retinopathy screening studies which have been done. The two basic main first two softwares are IDXDR and IART, and they both have shown high specificity and high sensitivity, which is great, which is a great start actually, and it gets even better. So it makes screening of underserved populations much easier. So say Nikunj could have gone to certain parts of Madhya Pradesh, he would have sent this AI technology with a oriented staff, and he gets a lot of data and he knows exactly which area requires his attention and doesn't. Similar goes for glaucoma detection. It's now coming to smartphones as well, the AI, so that it's less robust for everybody to go in. And in the end, it's basically get minimal and get maximal out of it. So ARMD also, it's already worked. Detection of wet AMD is now started, which is a game changer because that's exactly when you want your patient to walk in, and that's when you want to give your right treatment and prevent vision loss. So whole idea is to get there where you can reverse the cause of blindness. And of course the curse. The curse is basically leak of data privacy. We always worried, you know, there was a big article in the paper which said that are other companies benefiting from ChatGPT because a company A is giving in data, so it's using their numbers and it's getting its own. So yeah, misdiagnosis or missed data, which is something that Kaushik also threw light on. So I'm going to talk about a few challenges. Just take about 2 minutes. Is that fine? So first one is going to be data quality and diversity. So one of the main challenge we have is that it requires large data set, lot of good quality images. You can't have a bad quality image and send it to AI. So solution of this is basically getting a standardized protocol. That is still not established in all of it. If you have a standardized protocol, how to take a picture, where to take a picture, what sort of camera to use, maybe that will override this. The second challenge that it has is clinical integration. A lot of EMRs, we are very comfortable, we don't want to budge from it. So we have to find something which integrates into the existing mechanism, not say, okay, leave your EMR, come to us. That won't work because that means a lot of changes. Ethical and legal considerations, Kaushik has pointed out yesterday also, or day before also, he pointed out in somebody's presentation, why didn't you give credit, which is absolutely bang on. Because it's ethically right, it's to give credit to if you use anything from anywhere. Similarly, the legal considerations also future. If this data gets leaked, who's in trouble? So all these things have to be ensured. You have to have proper legal framework document which is signed by 3 parties, and then that's how it can look forward. Then most important, I feel, is building trust among patients and professionals. I think this is where a company progresses and it fails, or a system progresses and fails. If you have trust in the system, if you have a transparent system, I think it's easier. But when you don't know where this data is going, how it's analyzing, it's not easy for everybody to interpret in simple words. People don't want to use it. They're worried about what can go wrong. And future directions basically are different disease protocols. We can have integration with areas which are absolutely underserved, so that we can at least reach out to the people, and AI can be used for people who don't have the right doctor, the right medicine for them, and give us data sets that we know exactly where our efforts should go into. Not that we have 10 doctors in one population and we have 0 doctors in another population. So that's where AI makes all the difference. Of course, surgical planning in all AI is still very nascent. Like I said, the first vitrectomy just happened, so it's very different. And there are ethical parts to it. And the synergy is very important. Getting both sides together in a proper baseline is very, very important. And my slides go on. So concluding thoughts, it has already done pretty well. It's shock and awed most of us. That's why we're here talking about it. And we have to adopt it in the right way, get the maximum out of it, and needs further research and development. All right. Thank you so much.
So, thank you
These are
so
some
much,
cool
Dr.
things. Sorry.
Yeah.
This is what I've made from ChatGPT
Generative
for-
AI. I
yeah,
think
yeah.
Dr. Prasanna next will be going to talk about it. Actually, there was a lot of stuff in these slides, and I think each slide will encompass for it warrants a longer discussion. But I'll just take one point out of it, and then I'll ask the panel's opinion on it. Actually, we have been using AI in our daily clinical practice, like in OCT, RNFL. It automatically detects the optic disc margin and the cup margin, and then it gives us it analyzes and gives us the where the thinning is. Actually, it is wrong many of the times, but yeah, but how many of us actually go and correct those data? And if something comes like what he was telling in EMR, we put the symptoms and then it will tell the medicine. How many of us will actually change those medicine and use our brain if it becomes like that? So, panel's opinion on that.
I don't think first that it doesn't match. You very rightly pointed out especially the disc ratio. It doesn't match what we see with the indirect. It really doesn't match. And then we do not go and correct it. We do not do that. So we stick to our findings, and in the EMR, when we are putting down our EMR, we stick to our things. I don't know about the others, but that's what I do.
So I think what we in healthcare, what we are actually trying to focus on in AI as a whole is probably not wanting the AI to actually prescribe medicines, right? That is not what we want from AI at this point. That is where we want our input. What we want is basically diagnosis and prognostication that can help the patient, and to tell them follow-ups, and basically remote diagnosis is what has to be focused on. So I don't think this is prescribing medicines is what we want from the AI softwares right now.
So very correctly said, the data set is not that robust yet to give them that ability. Dr. Prasanna, your talk on generative AI and social media marketing.
Thank you, Nilesh. Thank you, Team YOSI, for giving me this opportunity to talk on generative AI. So I have no financial disclosures, and this is one of the methods that I have taken from my personal take. And I don't advocate generative AI. I recommend human-in-the-loop AI learning. So I'll just show you why, and we'll have a discussion after that as well. So this is Christopher Nolan. I think many of us will be knowing his movies, Inception, Interstellar, and whatnot. He recently won the Oscars for Oppenheimer. So I think most of you would have watched this scene, right, where the people they navigate in the stars. It's a dream sequence, but he actually recommends shooting it in real. He could have actually easily used a green mat for this, but he recommended shooting it in real because he doesn't want to cheat the audience, and he also feels you get the best out of the actor only when you do it real. So he made a rotator, and he rotated it so that they can walk through it 360 degree. He did the same thing for Interstellar as well. All the things that you see was actually really shot. There was no graphics, minimal graphics, or he doesn't use graphics at all in his film. But generative AI, so these are things that I also learned very recently for the talk, as well as how we can actually use it or not use it. So generative AI, as far as I know, it is a brain of its own, that it inherits certain capabilities like art designing, music, as Aditya was pointing out, right? Fraud detection and customer behavior analysis and whatnot. So generative AI models, I just wanted to give some video-based examples rather than more of theory. So for example, see, it comes with, this is a 3.5 ChatGPT. How can I help me today? I'm just putting it. Can you give me social media marketing strategies? It gives you n number of strategies. As you type, it works for you. The brain is actually not being used. That is always dangerous. See, the machine is actually now taking the lead and telling these are all the things that you can actually do, and it is actually helping us get the presentation ready in a way which I am not really advocating. So again, you can see this is another part where you can refresh, and you can also get even more. Defining your goals, identifying your target audience, choosing the right platform. Of course, you can use it, but always you need to study for social media marketing what is that your locality or your region wants, what is that your region demands, and give it more customized. This is like a textbook. Just take a pinch of salt and then you customize it by using human intelligence called human in the loop machine learning and not generative AI. But again, I just wanted you to show the flip side of it, of what generative AI is doing, and how, at the example at the last, how we are actually making an image for an artificial image or even an AI generated image. So see this again, these things are very scary, my dear friends. A human eye with, this is Deep Dream Generator, a human eye with the ocean instead of the iris. I'm just typing it, and you can see that search, this is removing the creativity part from us. You see how much of things you are getting, a human eye instead of a ocean. See, the iris has now become an ocean, and these are images that are generated. This is not good actually. So I think we are now coming up with a lot of artificial intelligence competitions. ASCRS has a separate competition for After Effects. There is a category called After Effects, which is one of the high profile categories which I participate every year, where I will show you how I make my images, not like this. So this is something which is very scary, because this takes away the creativity part of it. See, just 30 seconds you type whatever you want and you can get an image. So this is very bad for creativity part of it. I don't know how to put it more than that, because this is actually human. Where is the human intelligence here? Just typing is what is human intelligence. That is very dangerous. But again, this is another video of human eyes with logo reflecting on it. I'm just forwarding it. See again, these are videos that you can use for maybe your YouTube videos, or for some of the GIFs that you want to make for a OPL video or for a presentation, or even for social media marketing. This is fine. A video of a human eye reflecting with logos. Yeah, for marketing definitely you can use your eye logo or your logo that you are having in your hospital, right? You can definitely use it, and it will sound very unique for your campaigns in YouTube or for your social medias per se. There is again a fine line which you always need to keep in mind, which I am talking, because generative AI, if you see, there are so much of automation and there are so much of insights, predictive analysis, which is good. But at the same time, let us see the downfalls of it as well, because you need to know how you can be on the hierarchy so that you will be on top rather than not the AI being on top. Again, this is another dual perspective, AI in social media marketing. Coming back to AI in what I do it. So if you see the AI, we cannot escape AI. So for example, we all have the smartphone here. We use the face identification, the iris scanner or the fingerprint. So we have AI in our day-to-day lives, like the car that you can see here. It is now launched with a LiDAR sensor. It knows when to stop, when to start, or the NASA engine that has recently been launched, which is the first unmanned aircraft. So why, as Kaushik was talking on black box, right? If you are using an AI and you don't know why it functions the way it functions, you are in soup, because it can always pull your leg. Social media is never a joke. So when we started doing AI, we started to diagnose or crack the black box, because the rationale behind the predictions of it are not understood very clearly. So to overcome the black box dilemma, what we started doing is, we started utilizing human intelligence. So utilizing human intelligence in artificial intelligence. It's called human in the loop training. So what is it? It is just like a human anatomy of CNS and PNS. You can see the AI algorithm that I usually make are all HITL, human in the loop training. It has to undergo a similar baby growth. So I would advocate more of this, where for example, there are two human interfaces. One is the humans will teach it. Another thing is the humans will always validate it, because at the end, in the court of law, it's the human signature that matters, and AI can't come and defend you. So we use a lot of human training models like this, where you can see that we train the machines, and then the machine starts to learn with the AI algorithm, and then the predictions happen. Again, there the human will also have to validate it and put a signature. That is important. If it is wrong, then it has to go back to the module again, and these are some of the modules. Explainable AI is the future, be it for social media marketing or for anything. If you are not having an explainable AI model, it is always a tricky part. So all our work or my work that I am doing at my center are all explainable AI. So this is recently a multimodal imaging that we started, where why does the green pick up the trabecular meshwork? Why does the yellow pick up the scleral spur? And we are trying to form a multimodal protractor, and that has to be explainable. You can see that this is a novel protractor that we have recently innovated for the UBM, the Anterion, the ASOCD, the Sheem plug, and we are evaluating it again. And you also always need to have an explainability with good sensitivity and specificity. Even if it is going to be for a social media thing that you have, you need to know what is the AI sensitivity, what is the AI specificity, what are the things that I can have as, how can it actually cause trouble or something like that. Because again, you can see, if this image I am going to feed it in, so this is what you need to know about AI, because first, in the initial stages, the actual angle is 24.76. As I told you, right, the AI is learning. Now it is 27.9. In the second set, the same 24.76 is now coming 22. There is only a 2 difference. Now in the third one, you can see it's as close as possible. With human in the loop, you can always feed the machine more data, and you can customize the machine according to your preference. It will be something like your mirror image. So for example, when you launch any applications or other things, this is our own image that we are putting into the app that we made. So once you put this into the app, you can see that automatically you will get whether it is open angle or a closed angle and what are the angles. But it looks as if it's automatic, but a lot of human brain or human intelligence has gone along with the artificial intelligence. Again, this is another bimodal AI for OCT that we made, where we use the visual marker and the numerical markers. You can see the code. So this has been made by humans. It feels as if the machine is going to do the job, but the code, both the visual and the digital input, has been made by the humans to take it forward and then diagnose whether it is severe, mild or moderate. There are so much of human intelligence that is going in. So I always recommend HITL compared to the generative AI, because HITL, human in the loop learning, will always have your back. Definitely it's finally you that have to take care of it. But HITL is very promising. It helps you undergo a similar growth just like a human being. And some of our AI you saw diagnosis and intricate findings. We have the fundus, we have for the angle to differentiate between glaucoma, then we have the OCT to grade. So when you have holistic AI, it really helps you in a comprehensive working up of the patient, and you can keep working on more. So now we are moving towards mixed analysis, mixed angle analysis, where different KDB or bank, they have all different anatomies. So keeping in mind the technological advancements, it seems like this is the future. And where you can use generative AI is, I'll show this video again. So for example, so this is my startup. I'm just winding up in a minute or so. So hi, I'm Dr. Prasanna, AI clone. Somebody wants to approach me. Maybe you can have your own website, and this is my startup. So somebody wants to connect with me, like you have this right in Indigo, you have this in all the customer call that you try to see. So if somebody wants to know about me, so what has he done, so how can I approach him, so where is he now, so maybe you can do something like this. If somebody wants to know where you are, I want an appointment to meet him, so he's currently in Bali attending the APAO conference. So something like this you can customize, so that we all like to be active in social media, right? So these are some things that you can actually make sure you do it, and it will be very active and it will be going on well. So these are some things that you can, short and simple innovative things which will really work out for you. Of course, there are some simulations that we have done. I'll skip it because it's beyond the scope. But I always advocate AI which you can control, and these are some of my innovations and some of my presentations on HITL and not on generative AI. Because you dive into an experimental generative AI, it is always tricky. But I think you would have seen this video here in AIO is playing. So last year, 2 days back, they wanted a video of mine. I just gave it one. So I just put 4-5 photographs together, and if you want to make a quick video, I think then that's okay. You want to make a collection of videos. Everybody has a smartphone where you have those quick videos, right? You want to make all your AO's memories a video. I think those things are perfectly fine. Those are all generative AI. The machine knows how to pick up quickly, and it gives you a good AI. So in this era, this is one image I think you all would be knowing. With this, I'll be closing my presentation. In 2022, this was a cover page image that I published in 2022 AIOS conference. We took around, 4 to 5 days to make this image. It was not a generative AI, and this is how we made the image. I wanted to show you why generative AI is dangerous. We took a patient's photograph. We had to have the ambient lighting. We took the photograph from a side angle with an endoscope, hit the light with the Purkinje image, and you can see we manually worked on this. This is a ACRS, there is an After Effect category for it. They ask you how do you make the image. So these are some things where human intelligence is playing a major role, my dear friends. This is taking away our creativity. You can see how we are removing the reflection part. You are able to see the reflection part. I forwarded this video because I can't show the 5 days of work that went in creating this. Then you can see how we worked on the edges, how we are working on. It's like manual drawing, but it is like a digital drawing. You can see how the shadows are removed, how it is being worked, and see how we are going to give the periphery, the edges, and what not. So this brings the creativity out. There is something called digital creativity also, which is very, very important. And you can see that now we are adding on the stars, and you can see that finally how the image comes. It is always easy to type, can I get an eye starry sky? And the AI may give you something like this. But the joy in creating something from this to something like this and get it printed on a cover page image on the biggest national level podium, it's something really huge. I don't really advocate generative AI for this. So finally what we do is all for the community. make sure we protect ourselves first. And social media is something that is booming, and these are some of my social media handles. Always be caution, we are working together, but at the same time I would always say, if an algorithm is going to come which is going to terrorism or something like that, algorithm is destroy all the living human beings, that is dangerous for that. I'm not telling it is going to happen, but there are movies like Terminator and iRobot where if the machine starts to think, that is something we all don't know. So with that message, I'll end this talk. Thank you once again for the opportunity.
Thank you, Dr. Prasanna, and it's always inspiring to see the hard work even before, like even with the use of AI, you are like training them with your own brain. I would like to invite comments from Digvijay sir and Priya ma'am. The purpose of this talk also was to, like, in most of the cases when you give your social media marketing to an agency, most of the time they are using some generic images to do that. So if they are doing the generic images, there is no creativity, then why to pay them and why not to use an AI to do the same thing for us? So your comments on that.
So I think so there are two aspects to it. What Prasanna said, but even to generate the generative AI images, you do require creativity to decide what you want to tell it, because it's going to give you only as good as the input that you ask for it. Right? The question you ask is important. So even for that social media company that you may be hiring is probably using its creativity to decide what it wants to do next for you. Though the image may be a generic image that it picks up off Google or anywhere. So if you're willing to do that, I think there is nobody can be a better person marketing for yourself than yourself. Perfect. Actually. So that's what would be the right way to follow.
I think that's well said, sir. Nobody can market you better than you, and you can give agencies, but the thing is you just need to be sure that you are safe, because ultimately we need to take care of that element also.
I can only, I can decide what I want to show and what I want to showcase. So nobody else can do it. I think sir has already said it.
So I think sir has put it very right.
Very well. He's put it very well.
The person has to be on the hierarchy so that the AI is controlled by the human rather than the AI controlling the human.
Absolutely. I agree.
Current scenario, everything like every smartphone now that is coming with AI to enhance its capability, but still there are some limitations. So Dr. Nikunj is going to talk about that, the uses and limitation of smartphone.
So good morning to all, and I would like to thank Team YOSI and AIOS for giving me the opportunity today to talk about smartphone as an imaging device and uses and limitations. So everybody has a smartphone, right? I mean, you don't need to, like from chai wala, sabzi wala, everybody has a smartphone. So it's not like that it has a limitation that owning a smartphone, but how to use it is important. So these are the images. I'm going to show in few more also at the end. So all are taken by this phone in the center, that is OnePlus 5, which is a dear phone to me. I still have it, but there are no financial interest, of course. But I'm going to show how I have integrated that in my clinical practice when I was learning, and I have like tremendous data which has helped me grow. So all right, so smartphone is it is not just a phone, it is actually a phone, plus it is your laptop, it is actually a television, it is also a camera and more, and it is also a reading device. So you can choose how to apply it in your clinical practice, or and you can have your EMR and all those stuff based on AI and ChatGPT. My friends have covered. So there are so many publications recently with the use of smartphone in ophthalmology. It is very important tool if you are working in a setup where you get referrals from your primary centers in the periphery, so somebody can take image and send you on the phone just by taking on the phone, and it is easier to send on WhatsApp or whatever transferring channel you use. So it is easier to give that teleconsultation, but yeah, obviously somebody has to be trained to take those at least good photographs from the patients. It has been also been used for microscopic image in the microbiology, and that in that field also it has excelled. And somebody, I don't know the name, but there is a good publication. They have used IOLs and attached it to the iPhone camera, and they have taken wonderful images. So I mean, innovations and sky's the limit when you want to use smartphone as an imaging device. But I'll be just sticking to the clinical aspect of it. So any photograph which requires basically I would say three things. That one is object, one is camera, and one is light. So I mean, you don't need to learn everything about ISO and shutter speed. I mean, you don't need to be a professional level photographer to take a photo from a smartphone, because smartphone does that for you. But at least you need to understand what is the what kind of light it should be. For ophthalmology, I would say universal rule: just keep it in the dark room. You will get a good image with your phone. As simple as that. So there are multiple phone adapters now coming which can be attached to the slit lamp. So one is from no financial interest anybody. So Remedio has come up with a beam splitter in the which you can attach in the slit lamp between the eyepiece and the optical part, and then you can attach that is actually only for the iPhone. They have some collaboration with iPhone, so you can only use iPhone which they provide. You cannot use your other phone, and it gives a fantastic image. But it also uses a beam splitter. But what happens with the beam splitter is it actually splits the light. Only 10 to 20% of light goes to the camera, and rest of the light comes to your slit lamp. So whatever you're seeing is whatever the camera is getting. So it is actually less light. So I mean, kind of you are compromising on the illumination there and there. So there is another company which has come up with just a slit lamp adapter to hold your phone. There is nothing else. It is just an adapter to hold your phone. You just have to adjust first time that when your camera is in the alignment with your eyepiece, and every time you just have to click a picture, you flip it down, put your phone, take a picture, flip it up, and it again becomes your original slit lamp. And this was some old device when iPhones were also like in iPhone 4 level. So Dr. Fogla sir has also shown this in one of his videos there on YouTube. So there is kind of an eyepiece kind of structure attached to it. So it is devised by the company called Killer, but it is like there is another DIY version of it. You can just use some bottle-like structure with the they have used the shaving kit ka base and then make a eyepiece and connector, and then you just apply it in the slit lamp. But you need to remove one of your eyepiece and then click the picture with your phone. So there are multiple ways you can click the picture, and ultimately what important is that you need to have a better clarity image so that you can show it, and you can even show it to the patient, show it to your colleagues, and discuss whatever the way you want to. Smartphone now is also used as a video surgical device for microscope. We are using one from the Remedio, and it is giving fantastic video recording system. This is the video just to show. I'm not going to show the full video. So you can see this is the maximum zoomed out field of vision. There is only limitation which I felt with this particular model is that they have, after all, for microscope you need to use a beam splitter in between, because you need to use the microscope when you are recording. So there are like, you get this round edge, which is one thing that I don't like about this one, but otherwise the quality, resolution, you can even record 4K recording with this. So this is just a case of acute hydrops. I was doing some small procedure and just to show the recording. There are so many fundus cameras nowadays, like with handheld and stuff, but all you need in your clinical practice, if you want to take a fundus photograph, is just 20D, which all of us, I mean, generally have, and a camera. So with just 20D, and there is a publication by a team from China as well, and few more, that they take a 20D and a smartphone with flash on, and you just take an image right there and there. Of course, there is a limitation that the field you get is limited, and you cannot. I mean, it will be difficult to get the peripheral images in this kind of scenario, but posterior pole is easily, doable. I'm an anterior segment surgeon, so I think Dr. Kushagra is there. He's our VR surgeon at SRJ Netrala. He does that, and he will be able to share his experience more. So I talked about few adapters and this thing, but personally I don't use any. I just use the camera, and slit lamp is there, and how to take a photograph using nothing just for apart from your camera. I've made a short video for that. So I'd be grateful for my staff to help me with this video. So first thing is, obviously you need a cooperative patient. It will be difficult when you have a child as your patient and you want to click a picture. It is even difficult with you if you have a already established slit lamp imaging device. So first is you set the patient. So I use just 2 fingers. One is resting on the eyepiece, and other one is the index finger is actually guiding and holding my phone, and I'm actually moving my phone with the camera right and left, and you just wait when the image is actually formed, and you know where the image is, you are getting the image, and you need to be ready with your other hand on the click area with the thumb. So once you get an image, you need to hold the phone in a correct position, and you just click a picture, and that's it. So with the smartphone advantages are you don't need to worry about other parts of like illumination and stuff. So you can see the image, which is quite clear, and it is actually a slit image. So these are the few images which I have taken. So this is a subluxated case of cataract with anterior subluxation of the cataract, then viral keratitis, iridodylisis, a toric IOL in place, one of the peritoneal keratoplastic graft, ruptured anterior capsule phacomorphic glaucoma. So you can see in all images there are different kind of illuminations, and all these images are taken by just phone, nothing else. And if you like good images, I have made an Instagram page. I am not able to give a justice right now after becoming father, but there are very good images there which are all taken using just a smartphone on slit lamp. So advantages are that it is easily available, it is repeatable, it is portable. You can integrate tele-ophthalmology with it, which is the biggest advantage I personally feel. AI integration would be another level of using the smartphone as an imaging device. You can directly store the data on cloud, so you don't need to worry about hard drive and stuff. And transfer is also easy, but limitations are when you have an uncooperative patient, obviously it will be difficult to use. And after all, it's an iPhone or it's a smartphone, so any operating system can crash and you can lose the data, but you need to have a backup. And also the camera longevity. So I mean, any phone will get tired with age, and the camera will lose its clarity and stuff. So that needs to be replaced. When you can replace just a phone and you are good to go. So there are future applications. People from Sankar Netralaya with Microsoft, they are working on it, I think, and they've published already. So it is actually 3D printer made Placido disc model, which is used with LED lights, and it is actually just smartphone based corneal topography. So actually you will be able to do topography where in a camp patient, where you are suspecting something that it could be a keratoconus patient, and you might be able to give a better idea that he might be the keratoconus patient. You can bring it to the hospital, but the sky is the limit when it comes to using a smartphone in a smart way. Thank you so much.
Thank you so much, Dr. Nikunj, for the wonderful talk. And just before I invite comment from Dr. Kushagra and Dr. Pratyush, Dr. Aarti ma'am, you can set up the talk. So what I do for localizing, I'm not using any adapter. What I do is when you go back 2 centimeters from your eyepiece, you will see a small dot of light that is where the image is forming. So you just follow that dot, and when you go near it, it'll just keep magnifying and it'll show the image. So near the ocular, if you are just moving the iPhone up and down, it sometimes might scratch the ocular surface and the binocular surface and your smartphone camera also. So I used to do that. Dr. Pratyush, Dr. Pratyush and Dr. Kushagra's comment on.
So one thing what I do is sometimes when I'm not able to focus properly or get a proper image, or if the patient cooperation is not that good, I switch to the video mode. So when you switch to the video mode, sometimes you just miss that moment where you want to click or you want to get that focus. When you switch to a video mode, you capture the whole thing. Maybe you can, later share it to your laptop and, capture that image that you want to capture.
Yes. So I have recently bought the innovative product that Dr. Ashish Sharma has recently developed for taking retinal images. I'm yet to use it, but I have got the demo from himself. And otherwise, we use the smartphone to capture images from the slit lamp. Yeah.
I think the ease of use is the most. It's readily available everywhere.
Ease of use, readily available, repeatable, and easy to share the image also.
Yeah.
That is also important.
That is
it's not about just taking the image. You want to, use it.
So.
Smartphones, they apply too much of their AI also.
Yeah, they will. Just like if you click a picture, you are fairer than you are actually. So that is actually.
So the next talk will be from Dr. Aarti Heda, and she is the brain behind this session. She has planned most of the talks, and she is going to talk about robotic ocular surgery. Is it the future?
So good morning, everyone. We've been talking about technology since morning, so I'll take you all to a step forward. So let me ask one question to our panelists and the audience. How many of you think that there is a future for robotic ocular surgery? Okay, let's say 50% of the people in the hall say that there is a future. So I would like to thank YOSI and AIOS for this wonderful opportunity. These are the disclaimers of my presentation. I generally don't give it, but you're not allowed to sleep in my talk. You're not allowed to look in your phone, and you're not allowed to leave the hall, because this might be a little boring, little theoretical, but I really can't help it. And one more thing, I have not used any AI or chat GPT to create this presentation, so bear it with me. It's human nature to strive for perfection, may it be making chapatis or doing surgeries. Nevertheless, manual surgical procedures are constrained by the physiologic limitation of human surgeons. Precise physical manipulation of intraocular tissue is hindered by inherent hand tremors and inability to sense forces between these human tactile perception and lack of sufficient depth perception to resolve microstructures or identify the tissue planes. So, robotic systems have been widely incorporated into many surgical applications because of their higher precision, greater maneuverability, and potential for improved sensing capabilities compared with the manually performed surgical procedures. So, ophthalmology is one of the most enriched fields, allowing the domain of artificial intelligence to be part of its point of interest in scientific research. So, let's try to understand how robots are part of ophthalmology. So, these next 3-4 slides are very theoretical, but we will have to understand that why and how are robots going to be part of ophthalmology, are already part of ophthalmology. One method to categorize the range of intraocular robotic surgical system is according to the degree of human versus robotic control. So, in traditional surgery, the human surgeon controls a surgical tool and uses an optical microscope as visual feedback. So, we all know this. In robot assisted tool, the surgical tool itself is modified to a miniature robotic system. The surgeon controls this tool to perform a hands-on surgical procedure, while the robot tool offers tremor cancellation, depth locking and other features. So, example of this is Micron. In teleoperated robotic surgery, the surgeon controls a robotic system through joysticks and uses an optical microscope or digital heads-up display as visual feedback. The joystick motion is directly mapped to robotic motion, and therefore advantages such as haptic feedback, tremor filtering and motion scaling can be implemented very easily. Then is the cooperative robotic system. The surgeon holds the surgical tool simultaneously with the robotic system and uses a microscope, or let's say an OCT, as visual feedback. The surgeon maintains direct manual control over the motion of the surgical tool, while the robot system provides assistive compensation for hand tremors and allows for prolonged immobilization of the surgical tool. So finally, in a partially or fully automated system, the robotic system is tightly integrated with the microscope to provide feedback and guidance to the motion commands of the robotic system, which directly holds and operates the surgical tool. So, specific procedure or steps of a procedure are automatically performed by the robotic system, while the surgeon supervises through the provided visual feedback. Now let's talk about the practice. So now you can relax, the theoretical part of it is over. Now let's talk about applications for surgical robotics in ophthalmology. Laser-based surgical procedures such as femto laser cataract surgery has already provided superhuman level of accuracy and safety to lower intra-op and post-op complication rates. In addition, microscope integrated OCT have enabled improved visualization and introduced the ability to accurately sense depth during the surgical procedures through incorporation of a real-time OCT. By standardizing the treatment, a robotic system could enable every surgeon to improve the outcome. Another potential future benefit is reducing posterior capsular opacification through complete polishing of the entire capsular bag. Currently, human surgeons are limited by an inability to visualize the lens equator, the difficulty of sensing the position of the posterior capsule relative to the tool, and inadequate control of aspiration forces and response time. So, robotic solutions include the incorporation of novel visualization technologies capable of imaging the capsule equator, robotically guiding the tool positioning, and high resolution control of aspiration forces with fast response time. So, there have been multiple studies and they have proved a good role of robot in cataract surgery in animal models. So, robotic surgery play a role in every subspecialty in ophthalmology. So, retina is another subspecialty where robots have played a very big role. So played, there have been gene and stem cell therapy, macular surgeries, giving subretinal injections, retinal vein canalizations. So there have been various studies on the animal models in this regard as well. Various glaucoma procedures have also been performed by robots, like goniotomy and eye stent surgeries. Some of these steps have been done by human and some by the robots. So let me just tell you some points wherein we can say that robots do have a future. The routine surgeons could actually help, the robotic surgeon could help increase the healthcare access by performing routine surgery on patients with cataracts that are not complex. Seamless integration of all surgical steps into a single system could improve surgical flow and decrease the operation time. Robotic cataract surgery is well suited to automation because surgical protocol is remarkably consistent and comprises the same specific routine task. So technology could be used to reach more learners, evolving from one-to-one and one-to-many students. So of course, nothing can have, not everything will have positive impact. So there are some points which will make us think whether robot will be a future or not. Like they come with a huge cost. To put a robot in your theater, you need big amount of space. The surgical time might be increased in the initial phases. There will be always a risk of infection, there is steep learning curve, and there can be device malfunction as well. So I'll leave you with this thought that change is always essential. We definitely have to change. So I hope people, those who are not raising their hands before my talk, will now be convinced that robot definitely will have some role to play in future when it comes to ophthalmology. Thank you so much.
Thank you so much, ma'am. And actually, yeah, what we think we will employ thank you, sir. Thank you. So what we usually say, like you said, it will be employed mostly in the routine cases. In the routine cases, we can hand over the surgery to robot, and somebody will be supervising, and we will think that it is a smooth sailing ship. But we tend to forget that there is one human element that we can't eliminate, is the patient. The patient factor will always be there. There are cases which seem routine, and sometimes there will be the patient might move and they cause a PCR. Everything is going good, and then suddenly a PCR happens. Then will a robot that has been trained to do a routine cataract surgery will able to save the day, or will there be a provision for some human to step in that system, because that system, and there won't be any microscope or somebody just to immediately step in and take it over. So how do you feel about it?
So the robots are fit in such a way that they will not have any complication, and if there is even a single sign that there can be a complication, or let's say robot has caught the posterior capsule, the machine will stop. It will not move further. So that's what. So let's say a junior is operating and a robot is operating. You can definitely rely on a robot more than junior, because junior will not know when to stop, but robot will definitely know when to stop. It's not that we are giving everything in robots and we are sitting with coffee in our room and robot is operating in the theater. It is not going to happen that way. Robots are not here to replace us. They are here to help us. So we may have to decide that these cases, we can say that can be safely done. That does not mean that you don't have to be around. And we know that these cases definitely will. And it is still evolving. So there have been some incidents like 10 years back in orthopedics that the patient had to lose both her knees because it was getting operated by a robot and they were not able to intervene in between. And then people thought that it might not have any role. But then again, they made some changes and it does have a role in knee surgery now. So it is still evolving, but we can definitely say that it will have a role. How much and how, we still don't know.
When I was reading up for this, ma'am has covered the maximum part. See, removal of epiretinal membrane has been actually done. There are 3 cases in human eyes where subretinal injections were given by the robot. So you can definitely, as ma'am said, you cannot, robot can, help in like corneal trephination can be done by the robot. So of course it has to be taken over by the surgeon. So a part will be done by the robot. So it is going to make it easier, and there's also an audio feedback that you get in the robot. So they'll keep on telling you, they give you that feedback that where you're going, the depth level, depth perception that we probably won't be able to understand. So that actually reduces that. It's been seen that it's published that 50% chances of PCRs have gone down with the robots being there.
So, like the earlier model, Da Vinci was trained where there was actually a surgeon who was handling the movements, and it was just somebody eliminating the tremor. And then they started removing the human intervention altogether, as you said, and there was no provision for somebody to step in. So probably the future models will have some provision where somebody can step in and save the day if something happens. I think that will be the way forward. That way we can take because it will be a boon if it comes in a setup like ours where we can employ robot to operate throughout the day, and somebody just can take over just the supervision part. Then a lot of unmet need of cataract actually can be treated, and we can reduce the disease burden in coming days.
There was a huge discussion the other day on that let's say if a surgeon himself has too many tremors, will he be able to operate the robot, So what's the point? So we keep on saying that, tremors will be reduced with the help of robots. So probably they are designed in such a way that a particular amount of movement is allowed, and beyond this it won't be allowed. So somebody who's shaking a lot,
It is just like a camera gimbal where even if you are shaking your hand, the camera becomes stable when you are moving. So it becomes something like that based on gyroscopes. So Dr. Abu is here. I think he has got some other engagement and is not here. So that brings us to the end of the session. It was a very nice session, and thank you everybody for attending. I would like to invite all the YOSI members to come on the stage so we can have a group photograph.
म्यूट करना